call Dr. M. Veeresham as a professor anesthesia. He is from Great Eastern Medical School and Hospital, Andhra Pradesh. His areas of interest is difficult airway. He has presented more than 4 national papers. His achievements are faculty in national, state and zonal conferences. Welcome you, sir.
Thank you for the organizer giving me this opportunity in the session to be in the con session. Videolaryngoscopy should be standard of care for the tracheal intubation. I will differ in this. How many people are like to see the real image or the real person in this hall? How many wants to see? Kindly raise the hands. They want to see the image or the real person? How many? How many wants to see the image or how many wants to see the view of the larynx directly? Directly. So I will differ in this sense. Direct laryngoscopy is the one which will help you to see the larynx inlet directly under vision. This has been existing since long time, 1940, who has developed this laryngoscope. And this is the mode of intubation, every area of the interest of intubation, every place wherever the required intubation is needed. See how many people are having videolaryngoscope in their hand, in their practice in this hall? Videolaryngoscopes, not laryngoscope, direct laryngoscope. Videolaryngoscope, how many are having? How many are having direct laryngoscope in hand? This is the situation. That is why I differ. Videolaryngoscopy is not the standard of care. Direct laryngoscopy is the standard of care. Standard of care is a strong term because it carries legal implications. Most commonly, it refers to the reasonable degree of care a person should provide to the another person. In law, it is used to determine negligence and potential liability for a tort. I would be unwilling to serve as a consultant expert to testify against a colleague who served direct laryngoscopy as a primary approach instead of videolaryngoscopy, because practitioners really should use the tools with which they are most proficient in difficult situations, in intubation area, because it is a life-saving procedure. There is a research article in Open Access. Videolaryngoscopy does not improve the intubation outcomes in emergency and critical patients. Most of the times, we anesthesiologists in this area, we are working. A systematic review and meta-analysis of randomized controlled trials have been noted in Department of Anesthesia, Chiang Hospital in Beijing, China. Their reports are like this. Background is there is significant controversy regarding the influence of videolaryngoscopy on the intubation outcomes in emergency and critical patients. This systematic review and meta-analysis was designed to determine whether videolaryngoscopy could improve the intubation outcomes in emergency and critical patients. We searched the Cochrane Central Research Register of Controlled Trials, PubMed, MBES and Scopus database from database inception until 15th 2017 February. Only randomized controlled trials comparing video and direct laryngoscopy for tracheal intubation, emergency department, intensive care unit and pre-hospital settings were selected. The primary outcome was the first attempt success rate. Review manager was 5.3 software was used and the grade system was used to assess the quality of evidence for all outcomes. 12 studies have undergone with 2,583 patients were included in the review for data extraction. Pooled analysis did not show an improved first attempt success rate using videolaryngoscopy. There was significant heterogeneity among the studies. Subgroup analysis showed that in the pre-hospital settings, videolaryngoscopy decreased the first attempt success rate and overall success rate also by experienced operators. Whereas in the hospital setting, there was no difference between the direct and the videolaryngoscopy. One more evidence. So, on the basis of these results of this study, we conclude that compared with direct laryngoscopy, videolaryngoscopy does not improve intubation outcomes in emergency and critical patients. And more so in pre-hospital intubation area, even it is worsened by use of videolaryngoscopy when performed by experienced operators. Most of the times, the videolaryngoscopy is practiced most of the times in the mannequins only, not in live patients, 90% of areas. And there is a pro-con debate, videolaryngoscopy is standard of care for tracheal intubation. The reliability on videolaryngoscopy may degrade other important clinical skills when they are needed most. If videolaryngoscopy is adopted as the standard of care, airway managers may no longer practice and retain competency in other airway techniques that may be required in the event of videolaryngoscopy failure. While cost is also a barrier for broad implementation of videolaryngoscopy, those costs are normalizing nowadays. It may still be challenging for institutions to secure or purchase of videolaryngoscope for every intubating area location, as well as backup airway device as airway management care increasingly transitions. So, videolaryngoscopy limitations. Because videolaryngoscopy has limitations, some of which can potentially cause harm, and in some cases, an alternate device may be superior. Do not think it makes sense to give it the designation of the standard for airway management. Can I have a water, please? As an example, in the case of morbidly obese patient with sleep apnea and an unstable cervical spine, an awake flexible scope intubation is almost likely the. Thank you. An awake flexible scope intubation is almost likely the safest choice for airway management. So, it means videolaryngoscopy is not the standard of care. This is one modality of airway management approach. Direct laryngoscopy will serve 95 to 98% of the practice of anesthesia experts in present day for the last 150 years. In addition to the issues related to the difficulty with endotracheal tube placement, despite a Carmack line grade 1 view of the larynx, other complications related to videolaryngoscopy have been described. There have been several case reports of injury to the palate and tonsillar pillars during blind advancement of the endotracheal tube during videolaryngoscopy, predominantly with hyperangulated blades and stylet tubes. What my friend has told, hyperangulated blades are more useful. Of note, many of these injuries were not detected until extubation or re-examination of the airway for another reason. Greer et al. 24, who published a review of these types of injuries, suggests that they may occur due to the blind spot in the back of the mouth that cannot be visualized by videolaryngoscope, as well as the use of the rigid stylet that are provided with some videolaryngoscopy systems. These risks are smaller with airway devices that are placed under direct vision. Videolaryngoscopy has other limitations as well, like any device that uses a video screen, battery or screen failure can occur during use, and secretions or blood can obscure the video on the screen. Poor connectivity between the blade and the cable can also result in loss of functionality. In all of these scenarios, an alternate airway device might be more successful. Every patient is not the same, and the factors that contribute to difficulty are not always the same. Therefore, it stands to reason that one size does not fit all as far as which airway device will be most successful in each individual patient. If this argument is used, having standard of care for choice of airway device does not make sense, as every patient airway and physiology are different. VL should not be standard of care. In VL, the time of tracheal intubation takes more in videolaryngoscopy while intubation, and may increase hypoxemia during that procedure. If the patient is little bit ASA grade 2 patient, it may lead to hypertension and arrhythmias. In other words, risk of pharyngeal injury also is there. It is more expensive compared to direct laryngoscopy, may reduce skills with other airway devices. These are the references of my contribution. There is a comparative study of videolaryngoscopy to direct laryngoscopy for endotracheal intubation in pediatric patients. This has been study conducted in Manipal, Kasturba Medical College, recently in 2023. This shows direct laryngoscopy is the standard method for intubation in pediatric patients. The introduction of videolaryngoscopy brought a paradigm shift in managing pediatric airway. They compared the tracheal intubation techniques between direct and videolaryngoscopy with Macintosh blade 2 in pediatric patients between ages 2 and 8 years of age requiring airway management. The glottic view and the first pass success rate were compared and analyzed. They were divided into V group and the D group with the same age. The result, the time taken for intubation was longer in the videolaryngoscopy versus direct laryngoscopy. The Carmack-Lehano-glottic view was grade 1 in all the patients in the videolaryngoscopy group, while only 35 children showed grade 1 in the direct laryngoscopy group. So there is a significant increase in both in the heart rate and mean arterial pressure in the videolaryngoscopy group at 1, 3 seconds, 5 seconds and 10 minutes after the 1 minute, 3 minutes, 5 minutes and 10 minutes after intubation. So conclusion, the time taken for intubation was more in group videolaryngoscopy, but the glottic view was much better, and the requirement for external maneuvers were compared. It is less maneuvers were done with videolaryngoscopy. Pressure response to intubation was more in group videolaryngoscopy compared to the group D. So direct laryngoscopy with laryngoscope is more reliable, user friendly, handy, economical, quick to use, rugged instrument, universally available, versatile. You can manage single-handedly. It is non-combustible. It is easy to sterilize. Suitable in all places of work environment like ICU, critical care, NORA, OT, RICU, out of the hospital. Pre-hospital areas also we can do it. Use this laryngoscope. So directly laryngoscope, they are existing since 1940. Advantage is quick to use, economical, rugged, universally available. Only alignment is one problem in some patients. So alignment can be taken with oropharyngeal axis, laryngeal axis. By this procedure, this is the photo. History, it was existing since 1854. Procedure wherein the larynx is visualized, performed for diagnostic, therapeutic, intubation purposes by various specialists. View of the larynx will be like this. Carmack-Lehane score will be with the laryngoscope, like this, 1, 2, 3, 4. And uses endotracheal intubation, insertion of nasogastric tube and transesophageal echocardiac probe, foreign body removal, upper airway lesions, biopsy, visualizing and assessing the upper airways also can be done. So you have only 3 parts in the laryngoscope. One is blade, one is handle, one is source of light. Available in various sizes and difficult places of use. Short handles will use for with females with big chest, and cricket pressure is also being applied. So Patil Syracuse handle blades are available with variety of patients wherever Patil, so many names are there in difficult situation. You can carry in one bag with the laryngoscope handle with the different types of 4 or 5 blades. We can do well better 95 to 98% of the laryngoscopy. We don't require any light source from outside. So these are the things. I want a second. One second one. Part 2. Come here. I'll take 1.5 minutes, 2 minutes. Part 2. Okay. We make it big. Okay. Few specific blades I want to show for simple laryngoscope. See Magill's blade, Oxford infant blade for infants, polio blade for those obese patients with short neck, restricted neck immunity, best hypertrophy, flexible tip blades, McCoy with laryngoscope handle. So McDosey blade modifications, edentless patients, double lumen tube placement is very easy with this McDosey blade, but it is not useful with bucket teeth patients. So straight tongue with this Robert Shaw blade, Wisconsin blade, left-handed McIntosh blade for left-handers. Only simply you change the blade. English McIntosh, Albert and McGill's blade, Oxyport blades, Tull suction blades, Fink blade, Bizarre Griffith blade, profile blades, Matthews blade, West Forager blade. There are so many blades. In addition to that, videolaryngoscopy not the 90%, 90 to 95%. We are having so many gadgets. Fiber optic laryngoscopy is in front of the axis, neck is there. Supraglottic airways are there. And McIntosh and Miller blades with laryngoscope blade. This serves the ultimate purpose with the little cost and more effective. Thank you for all this. Thank you very much.